My name is Dr. Jennifer Evan. I'm a board certified neurologist and a subspecialist in headache medicine and facial pain. Today, we're going to be talking about what is trigeminal neuralgia and how is it treated. So, trigeminal neuralgia, it's a kind of a mouthful of a name. Um, it refers to a facial pain disorder, usually on one side or what we call unilateral, and it affects a branch of a cranial nerve called the trigeminal nerve. The trigeminal nerve just means a three-branched nerve, and there's three divisions which we'll come across in a couple slides here. This facial pain disorder is considered a rare disorder. It's not the most frequently condition that we see in our headache medicine clinic. Even as a headache medicine specialist, we see a lot more of, migraine and several other conditions. So cluster or trigeminal neuralgia is a relatively rare condition. Different epidemiological studies will estimate it at different incidences, but 3 to 6 in 100,000 people, all the way up to roughly 20 to 50 per 100,000 people. And that roughly translates to 0.03% of the population. There is a slight predominance, or a 2 to 1, or some studies quote a 3 to 2 ratio between females to males, meaning females are slightly more likely to be affected with this condition. And the highest range of ages that are affected are 50 to 60s, though we have seen this condition in people who are younger, even including 35 to 50, and sometimes even younger than 35 as well. So, how do you get a diagnosis of trigeminal neuralgia? Well, of course, evaluation by a neurologist, who is a type of doctor who obviously deals with the nerves of the body, including the brain and the facial nerve. But other providers can often be helpful in leading a patient to a neurologist or to a formal diagnosis. In my clinical experience, I've had patients who were given a pretty accurate diagnosis, or at least a thought of, hey, this sounds like it could be trigeminal neuralgia, from providers including dentists, oral or maxillofacial surgeons, definitely emergency room physicians, as well as even primary care doctors, family medicine doctors. Would be your most common people who might encounter this before you are able to meet or consult with a neurologist. We're going to go over many treatment options for this condition, that although the condition is rare, we do have a lot of options. Typically, pharmacologic treatments or medications is our first approach to treating this condition, but we do have other non-pharmacologic treatments that we'll discuss as well in certain cases that might be utilized. So let's dive into a little bit more about the background of trigeminal neuralgia. We have a manual called the International Classification of Headache Disorders, which kind of classifies and organizes all of our different headache and facial pain conditions that have been widely studied over many decades. And in part 3 of the ICHD, we see a category called neuropathies and facial pain. And these are facial pain conditions attributed to a lesion or disease of the trigeminal nerve, would be what we would be talking about for trigeminal neuralgia. And there are 3 subtypes that we typically try to classify if we have someone with trigeminal neuralgia. Classical trigeminal neuralgia is the most commonly encountered, and that's where we actually see what we call neurovascular compression as what we think is the cause for the facial pain condition. Neurovascular compression refers to a blood vessel or some sort of vascular structure that is compressing or leading to some inflammation of the nerve. Another subtype is called idiopathic trigeminal neuralgia. And idiopathic refers to essentially we don't know why it comes about. From the Greek there, meaning idio, from within. We don't have a great idea of what causes it. No obvious lesion or structural cause. And then finally, we have secondary trigeminal neuralgia, which we sometimes encounter in the neurology office. And this might be someone who has a facial pain consistent with trigeminal neuralgia, but it occurs after something like a facial trauma, perhaps an assault, or some sort of a concussion, perhaps a surgery, an ocular surgery, or some other cause. Which, when we talk about secondary causes for trigeminal neuralgia, really the ones that we have seen that are not common, but we can see are things like multiple sclerosis, as well as things like masses or tumors, and other sources of inflammation. So the definition of trigeminal neuralgia is described as recurrent paroxysms or brief attacks, to use other words, of unilateral facial pain in the distribution of one or more divisions of the trigeminal nerve. Remember that trigeminal nerve has 3 branches, which we're going to see on the next slide. And you should have no radiation beyond the branches or the distribution of the trigeminal nerve, as well as some of these other criteria. So the pain is typically characterized as lasting very brief periods of time, from a fraction of a second, or a second or several seconds, all the way up to about 2 minutes. But the majority is in the briefer portion of just a few seconds. It is a severe intensity, and usually described as electric, shock-like, zap, shooting, stabbing, or sharp in quality. And then the second major criteria is precipitated by innocuous stimuli within the affected trigeminal distribution. What that refers to is touching the area described or affected by the pain can actually trigger the pain. So when we're talking about the trigeminal nerve, which is that facial, this cranial nerve on the face, different movements like a cold breeze, touching the skin, shaving the face, even sometimes chewing, or putting on makeup are all some of these innocuous stimuli that can actually trigger the pain to occur. And that's part of our criteria for trigeminal neuralgia. And then, of course, finally, not better accounted for by another headache disorder. So now let's go a little bit deeper. Here's an anatomical sketch from one of our medical anatomical sketchbooks that shows a lot of the structures of the face. Obviously, we don't see these with the naked eye, but under the surface of the skin, we have a lot of nerve branches. These nerve branches in yellow are really what we're talking about when we talk about the trigeminal nerve, or the sensory nerve that supplies sensation to the face. Over here on the left-hand side, you'll see 1, 2, and 3, and those are those 3 branches of the trigeminal nerve. The first division is called the ophthalmic division, and that branch, as you see here, is heading towards the forehead or upper eyebrow area. Your second division is the maxillary division, which, as you follow this branch, is heading towards the midface or maxilla region, including the upper teeth. And the third branch is the mandibular division. And as its name suggests, it's heading to the mandible or jaw region. So really supplying the lower 2/3 of the face, lower jaw, as well as the lower teeth area. You can also see in this slide, there are some blood vessels that are pretty intimately located here with the nerve. And then, of course, you get a little bit of a suggestion of some of the muscles that are involved here of the face for facial movement. So a lot going on in the face as far as nerves and blood vessels. Here's another kind of pictorial demonstration of what we're talking about when we talk about the trigeminal nerve, which again is a cranial nerve. And by that, we mean a cranial nerve is originating from the brain, and it leaves the brainstem, follows a small course, and then eventually leaves the skull through a small hole in the skull called the foramen ovale. And after it leaves that skull, these cranial nerves then supply or do functions to the face or neck region. In the case of the trigeminal nerve, again, you see it here originating in the brainstem. And then you can see this kind of bigger hub-looking structure, which is what we call the trigeminal ganglion. And shortly after that ganglion, you see the three divisions: ophthalmic, maxillary, and mandibular division. And over here in the colors, you get a little bit of a better idea about the areas that are affected by each branch. So ophthalmic is really going to be just the upper forehead, eyebrow, part of the eye, and this kind of top mid part of the nose. The maxillary division is really going to be your cheekbone, as well as the upper lip and upper teeth. And then your mandibular nerve or mandibular division is going to be the jaw and lower teeth area. So we mentioned neurovascular compression earlier, and that is really what we think is the main cause for what we call classic trigeminal neuralgia. Classic trigeminal neuralgia is up to 75% of those who have trigeminal neuralgia. And again, here to put a picture to what we're describing, basically, as the trigeminal nerve is leaving the brainstem, there might be a blood vessel that is making contact with the nerve. You can see here the red indicating a little bit of, you can hypothesize some inflammation or some compression. When I explain this condition to my patients, I often liken it to having like a tight hairband around your wrist, or having that hairband a little bit too far up your forearm. And if you leave it there for several hours and you move it, you'll see a small dent or compression in the area of the skin. And that really is kind of similar to what's happening when you have a blood vessel, particularly if it's a pretty firm-walled blood vessel like an artery that is laying on or coiling over the trigeminal nerve. Eventually, over time, it leaves a little bit of a compression dent, if you will, in the surface of the nerve, which we call the nerve sheath. And that basically stimulates a cascade of some inflammation and other neuropeptides and different inflammatory markers to be released, which we think is what's causing the pain to be triggered, this brief lancinating pain of trigeminal neuralgia. Now, we have a lot of arteries, of course, in the brain and the brainstem to supply circulation, but the most common culprit for trigeminal neuralgia, compression of the trigeminal nerve, would be the superior cerebellar artery. However, other arteries and even veins have been found to be compressing the nerve. Things like the anterior inferior cerebellar artery, as well as veins, which typically are not as firm-walled or pulsatile as arteries, but really any blood vessel could compress or have contact with this nerve. So when someone has trigeminal neuralgia, how might they present? What symptoms would they have, and what's kind of the most common thing we see? Well, 70% of patients with trigeminal neuralgia have seen a dentist or an oral surgeon prior to any medical doctor, because the most commonly affected branches of trigeminal neuralgia is that maxillary branch or second division, as well as the mandibular branch or third division. And as you just saw from the previous slides, those divisions are the ones that lead to the midface, upper teeth, jaw, and lower face, respectively. So when someone has trigeminal neuralgia, it often presents as a facial or dental type pain. And of course, if someone's having a dental type pain in the upper teeth, they tend to make an appointment with a dentist or some other sort of oral or maxillofacial surgeon, which of course can lead to some x-rays and radiographs. Now, of those who have seen a dentist, 40% or almost half have had some sort of dental procedure done. Those can be things from cavities being filled all the way up to root canals, as well as teeth being pulled, because the pain can be so convincingly dental or oral in origin from the upper teeth or the lower teeth. From a clinical perspective, I would agree with the studies that show this, as the majority of my patients did see a dentist prior to being sent to a neurologist, either by their primary care or by self-referring to a neurologist, or by going to an emergency room and getting a consult to a neurologist. But the overwhelming majority did see a dentist prior to a neurologist. And I would agree that at least half of those patients did have dental procedures. Clinically, I've had several patients who have had root canals done, and even one patient that had 3 root canals done until they were told that we don't think this pain that you're having is dental in origin. So unfortunately, this can be one of the main mimickers of trigeminal neuralgia. So what happens if you have idiopathic trigeminal neuralgia? What would then have caused it? Well, studies show that in the group who have idiopathic trigeminal neuralgia, which again is not more than 25% of cases because we think the majority are caused by that neurovascular contact. But in those who we don't see a clear neurovascular contact, there could be other contributors to why that trigeminal nerve seems to have some irritation or inflammation to make this brief kind of zapping facial pain stimulus. So the narrowing of the foramen or ovale, which I mentioned, is that small outlet in the skull bone where the trigeminal nerve passes through in order to sort of supply the face. In people who have trigeminal neuralgia, it has been found to be narrower than those who do not. Similarly, because the trigeminal nerve arises from a part of the brainstem called the pons, and towards the pons or cerebellar angle, people who have a smaller back of the brain anatomically, if you do measurements on imaging scan, might be more at risk for trigeminal neuralgia because, again, structures are just a little tighter in that area. There could be other contributors like excessive activation of pain pathways after some unknown trigger, or differences in pain modulation pathways that have been erroneously activated. Research is still ongoing to see if there are further reasons why someone might have idiopathic trigeminal neuralgia. It is important to note, though, however, that if you repeat brain imaging, which we'll talk about, but an MRI of the brain is always done when you suspect trigeminal neuralgia in order to see if there is a neurovascular contact. But if you don't see a neurovascular contact, like we talked about on a previous slide, it's not unreasonable to re-image a patient at around the 1-year mark or even sometimes later, especially if their pain is atypical, if it's bilateral, if it's not really responding to medication, because there have been cases and case reports that show that for whatever reason, sometimes if you repeat an imaging study, you can sometimes find that neurovascular contact or compression subsequently seen, even though it wasn't seen on the initial scan. Neurosurgeons have also remarked upon that in some cases, when they go in and do a procedure for a patient with trigeminal neuralgia, even though the imaging did not show a neurovascular compression, sometimes when they go in there, they do indeed find a blood vessel that is compressing the nerve. So unfortunately, sometimes our imaging studies do have limitations, but we do think the majority of cases have a culprit blood vessel that might be initiating or triggering the sensitivity of the nerve sheath. So a little plan for the diagnosis. Of course, you're going to have a clinical history where someone, whether it's again the emergency room or the dentist or your primary care doctor, says, this sounds like it could be trigeminal neuralgia. So that clinical history is going to include usually one side of the face or unilateral, pain in the midface or lower face. The maxillary or mandibular division is the most common, with the upper division or ophthalmic division being the least commonly affected by trigeminal neuralgia. And again, it's described as paroxysms, which are brief attacks of pain, usually for a few seconds, versus a lower quality, duller, continuous pain with then superimposed briefer kind of electrical or zaps of pain. And again, you need to have that triggered by sensory or innocuous stimuli, things like light touch or breeze or wind on the face, shaving, putting on makeup, sometimes cold stimuli. So imaging, as you can see here, is definitely part of the diagnosis. That imaging is ideally with an MRI of the brain. And ideally, we are going to on contrast with that imaging. There are sequences or different types of settings that the MRI machine can be set to perform to look at the brain in special ways to get a better look at the brainstem, which again is where that trigeminal nerve is really coursing until it exits through the foramen ovale to the face. Um, so we call those sequences in the neurology and radiology worlds things like a CIS sequence or a Fiesta sequence, but basically those are going to be doing as thin of cuts as possible on the imaging study on the MRI machine to really not miss any small areas of contact with the trigeminal nerve, which, as you can imagine, is a small structure in the brain. If someone cannot have an MRI done because of metal in the body, then of course other imaging can be done with a CT scan instead. You would want to have a CT scan of the head as well as a blood vessel study, which we call a CT cerebral angiogram, because again, you want to see both the structural anatomy of the head as well as a little bit more about the course of the blood vessels that leave the brain and the brainstem to see if there's any contact. There are other contributing procedures that can be done to confirm a diagnosis, such as trigeminal evoked potentials, where we use a little bit of a neuromuscular stimulus to kind of see how well the trigeminal nerve is transmitting impulses. But we don't typically need to do that most of the time. It's as long as someone can have an MRI of the brain, that's really the gold standard imaging study that we prefer. After you have those two parts, your clinical history and your imaging, or simultaneously, of course, consultation with a neurologist is highly important. The neurologist is going to rule out other pathology, things that can mimic trigeminal neuralgia, including other types of neuralgias, other headache syndromes like cluster headache, perhaps, migraine even, other types of primary conditions like persistent idiopathic facial pain. Things like herpes zoster outbreak on the face can cause facial pain and other sorts of conditions. So if you have a diagnosis of trigeminal neuralgia, you have all the pieces of the puzzle, then what do we do? Well, treatment is, of course, one of our big questions, and we have a lot of options for treating trigeminal neuralgia. However, because it is considered a rare disorder, we actually don't have any FDA-approved medications for trigeminal neuralgia. And that by nature of the rarity of the condition means we just don't have large enough studies to get Food and Drug Administration approval of any one medication to treat it. You need to have really large studies that are, replicated multiple times by multiple groups and done in a certain way in order to get FDA approval. However, we have many, many medications that have been used for numerous decades to treat the condition, and they do have substantial studies done. Things like meta-analyses, case series, controlled placebo-controlled studies. So we do have a good substantial amount of data, just not enough to get an FDA approval for any one medication. Our main medication that is our go-to first line for treating trigeminal neuralgia is a medication called carbamazepine. And carbamazepine has what I like to call oxcarbamazepine. And you can see the similarity there with the name, the generic medication name. And this class of medication that you see here listed at the top is really our first line therapy for trigeminal neuralgia and seems to have the largest volume of data for treating this condition. This medication is considered an anti-epileptic medication, meaning it is approved by FDA purposes for treating seizure disorders. And, from a neurological perspective, seizure disorders are not terribly different than what we call neuropathic pain, because both nerve pain and seizures are transmitted by nerve impulses or messages along a nerve sheath. This class of medication is also what we call a voltage-gated sodium medication, which is where it acts on the nerve. So this class of medication can be pretty effective, but as with any medication class, there are things to monitor for that your neurologist will talk with you about if or when you try this medication class for reducing the facial pain of trigeminal neuralgia. This medication is often taken 2 to 3 times a day, sometimes even 4 times a day. So it can be relatively short acting, roughly 6 to 8 hours of efficacy, though in some cases we do have extended release tablets, and for some people they metabolize it slower and it can be 12 hours or just twice a day. And as I mentioned before, there are things to monitor in the blood work. If someone does get efficacy from carbamazepine or oxcarbamazepine, things we watch for would be sodium levels in the body, as well as certain blood counts. Sometimes liver function can happen, liver dysfunction, so we keep an eye on that as well. Side effects can be common. While some people tolerate this medication class beautifully, others will have side effects, with the most common side effects being sedation or sleepiness, dizziness or balance issues, as well as even cognitive dysfunction. People who are older might be more susceptible to these side effects. So we tend to be a little bit more cautious if someone's older than 65 or 70, starting them on this medication, and you have to watch closely for side effects and the dosing to make sure you have an appropriate balance of efficacy for treating the pain with minimal side effects. After you carbamazepine or oxcarbamazepine, or if you cannot try carbamazepine or oxcarbamazepine, as you can see here, we have no shortage of other medications that do have data for treating trigeminal neuralgia pain. In the first category, you see other anti-epileptic medications. So these are all medications that are FDA approved to treat seizure disorders. Medications like lamotrigine tends to be sort of next in line for many neurologists to consider after carbamazepine. Other medications include gabapentin or pregabalin, levetiracetam, lacosamide, topiramate would really be kind of third line options, zonisamide, phenytoin, sodium valproate, and several others as well. So all things that could be considered and could be used with different degrees of data via case series or smaller case reports. Another category of medication that can be used is muscle relaxers. Baclofen tends to be the bigger one in this category than tizanidine, but tizanidine has had some use. Baclofen has a little bit more efficacy data, and some neurologists really favor baclofen as their second line option after carbamazepine, or sometimes with carbamazepine, which we'll talk about as well, using a more than one medication approach to adequately treat the pain can sometimes be not only tolerable, but helpful to treat the pain from 2 different mechanisms and help us keep side effects and dosages lower than using one medication class at a higher dose. Other pharmacologics, which I put focal onabotulinum toxin here, is technically considered a pharmacologic or a medication, but that's not something you take orally in tablet form. Onabotulinum toxin would be injected in an office procedure. Onabotulinum toxin is FDA approved for migraine, which is another headache disorder that does involve the trigeminal nerve, but obviously is independent and quite different than trigeminal neuralgia. There have been quite a few series of studies around the world using onabotulinum toxin in a focal manner to treat trigeminal neuralgia pain with pretty good results, which we'll also cover here in a bit. And then, if you look worldwide, what do other countries do and other neurologists? There are other classes like the serotonin norepinephrine reuptake inhibitors, or what we call SNRI, as well as the tricyclic antidepressants, or what we call TCA classes, that sometimes can also be used for this condition. But in the United States, we tend to use those less frequently than the anti-epileptic classes. And then towards the bottom, you see non-steroidals as well as opioids listed. Again, in the United States, from a neurologist and a headache medicine specialist perspective, we don't see too much use of non-steroidals or opioids for trigeminal neuralgia. However, in studies worldwide, in different Asian countries, I have seen those being cited as more routinely used. So there may be some data there, but again, just differences in the neurologist or where you are being seen. So here's a little data a chart here showing the data we just talked about. So again, I listed carbamazepine, oxcarbamazepine at the top, and you can see the number of randomized controlled trials, or RCTs. And that's really one of our highest levels of studies that we have in the medical world to really highly objectively study something compared to a placebo to see if there's true efficacy there. So quite a few studies for carbamazepine, a good number of patients there. And this chart was taken from a publication in 2021 that kind of summarized what we have in the literature. You can see that the doses range from maybe 800 or 400 milligrams twice a day, all the way up to 1200. And a good portion of people will get pain relief. So 68 to 100%. Really, the question is clinically if they're having side effects and if those side effects like sedation or dizziness are tolerable, to trade off between the benefit of reduced facial pain for this very painful condition. Next, I want to point some attention to things like lamotrigine, which I mentioned is a pretty popular one by neurologists for this condition. It has an 85% responder rate, which is pretty good. Gabapentin does seem to have some good-looking data here with 16 RCTs. A good number of patients have been put on gabapentin. It's a pretty safe medication to try compared to some of the other medications on this list. And doses can go, again, quite high in range for that medication class. The responder rate listed in this chart says similar to carbamazepine, so 68 to 100%. However, there is a note on the bottom that mentions that the gabapentin studies this meta-analysis looked at were mostly or all in the Chinese language, and the results were difficult to assess. So again, we don't know the quality of the data for gabapentin. Otherwise, if we looked at just this, it would seem to be that gabapentin would be more popular in the lead. But in the United States, carbamazepine, again, is our first line choice, or its quote unquote cousin, oxcarbazepine. Other ones here, baclofen, which I mentioned earlier, has a 70% responder rate, and a lot of neurologists will use for different facial pain conditions, as well as that focal onabotulinum toxin, which has a 68 to 86% responder rate. So again, pretty good. And botulinum toxin would not be an orally absorbed medication, so really has minimal side effects, which gives you why that might be an attractive option for pain control for trigeminal neuralgia if people respond to it. So another thing that I want to talk about with treatment of trigeminal neuralgia, or the course of trigeminal neuralgia, is that when you follow someone as a neurologist with trigeminal neuralgia, yes, you are doing a lot of medication tweaking and doses, because again, our ultimate goal is to maximize facial pain relief with minimal side effects and with the most tolerability for someone. But trigeminal neuralgia can remit or kind of weaken, or even, potentially being described as sort of has resolved or stopped temporarily. Um, and that can be really non-specific. There's really nothing in the literature that has any identifiable pattern of what interval someone with trigeminal neuralgia might expect to see a remitting of the pain or a weakening or temporary resolution of the pain. It could be months at a time. It could be even years where they just don't seem to have the pain much and may be able to go way down on doses of the neuropathic pain medications and sometimes even all the way off until the pain might flare or relapse again. About a third of patients will have a chronic pattern, and by that we mean when the facial pain begins, that's consistent with trigeminal neuralgia. They really just consistently have it from that point on, and they don't have those intermittent or variable time periods of less or resolved temporarily facial pain. So again, 2/3 of patients, if you follow them long enough, can have these temporary remissions, um, which, I think is obviously a good thing that it allows for doses to come down, periods of time without the medication, or sometimes even all the way off for the treatment medications. Another thing that I want to point out is that sometimes the duration of time someone has had trigeminal neuralgia symptoms for before seeking treatment or finding themselves to a neurologist for effective treatment may have an impact on how durable or long lasting the pain might be. Because the longer that blood vessel has contact with the nerve and the longer the facial pain is triggered, um, it can actually set off more complex pathways in the body involving sensory perception areas in the brain. So, of course, the way we feel pain is by perceiving it, which is actually a brain or cortical function. So, even though you feel the pain in the face, that nerve that's being irritated or compressed is actually sending the messages of pain or inflammation all the way to the cortex or outside surface of the brain. And that's how we perceive pain. So there are chronic changes that develop the longer someone has nerve pain or neuropathic pain conditions. So we really do want to get the pain under control to limit the amount of changes that we have in pain perception and these complex pathways of centralized pain. So when we think about focal onabotulinum toxin, which I listed under the pharmacologics, but technically is a procedure where we inject onabotulinum toxin into the face in hopes of decreasing the facial pain, similar to the mechanism that we use in migraine headache. There have been several case reports, case series, as well as systemic reviews, which again is a pretty objective, good quality type research study, a systematic literature review. And in this large study from 2020, so relatively recent, showed that if you do focal Botox in the area of the distribution of the facial nerve, the number of brief paroxysmal spasms or brief attacks of facial pain that a patient experienced decreased by anywhere from 55, there's a typo there, to 70%. So a pretty good reduction from 55 to 70% in the group that did get the onabotulinum toxin compared to a 10 to 30% reduction in those brief zaps of pain in the group that received the same spots injected, but with saline, not with onabotulinum toxin. And this systematic review looked at, many studies that used focal Botox, many groups, and the majority of these groups used 25 to 75 units. But each group had a different, slightly different set of points and slightly different number of units used. Other treatments. So, that laundry list of medication seems a little daunting, but it's not really for the patient to worry about. A good neurologist is going to walk you through your medication options. It's not, a recipe that everybody gets the same order. And really, it's a customized approach to try a medication or two, or sometimes three, or sometimes even more, in hopes of getting the patient's facial pain well controlled with minimal invasiveness or disruption to their quality of life, again, with minimal side effects. However, if someone has trigeminal neuralgia pain that does not seem to be responding well to medications. Either it's just not going down with the pain medications and the person is taking them, or they're not really able to get to very good doses on the medications due to side effects. There are non-medication options, which are typically through neurosurgery. For the majority of patients, again, who have classical trigeminal neuralgia, which is where that neurovascular compression, more than just contact, is happening on the imaging with a blood vessel kind of compressing the outside nerve sheath, there are procedures. The main one would be something called neurovascular decompression, where a neurosurgeon would essentially physically move the blood vessel that is laying on top of or disrupting the trigeminal nerve from that location. There are other procedures that a neurosurgeon can do as well, things like glycerin rhizotomy, balloon compression, using radio frequency thermocoagulation of the trigeminal ganglion, or things called gamma knife or radiosurgery, which we'll talk about and are slightly less invasive. So the main surgery, neurovascular decompression, which a patient might be a good candidate for, again, if they fall into that main group of about 75% of people with trigeminal neuralgia that do seem to have a blood vessel visualized on MRI of the brain that is seeming to compress or cause changes to the outside nerve sheath of the trigeminal nerve. That condition is a neurosurgery done through a small keyhole incision through the bone in the back of the head. It does have an 80 to 90% effective rate in reducing the pain. And of note, sometimes this is not full resolution of the pain. Sometimes it is reduced, which means that sometimes the patient may not need medication at all and may have a low level of pain. Or infrequent paroxysms or zaps of pain. And sometimes they may still have pain that requires medication, but they would not need as high of doses as they needed prior to the surgery. There is a chance that this can recur despite moving the blood vessel. And the neurosurgery literature quotes about a 20% chance of pain recurrence within about 5 years of that surgery. The other procedures that are slightly less invasive but still require a neurosurgeon to perform, where they take glycerin or a chemical substance to kind of deaden the part of the trigeminal nerve that is sending the erroneous pain to the face, or they use radio frequency to ablate or thermocoagulate the trigeminal hub or ganglion. With those procedures, they have much less invasive ways of accessing that area, but different outcomes because of the way they're done. Oftentimes, there's a higher risk of numbness on the face in the distribution that you are either ablating or targeting. So, of course, instead of just having lack of pain or decreased pain, you might actually have the absence of sensation in the area, whether it's the midface or the lower face. Other things like gamma knife doesn't require anesthesia, is really quite safe for patients who might be older and not good surgical candidates, and has, a low risk of facial numbness, but it takes a while for that procedure to kick in and has a little bit lower effective rate in reducing pain and a little bit of a higher recurrence rate. But certainly there are quite a few options to discuss with a neurosurgeon if your pain does not seem to be adequately controlled with the medication and on a botulinum toxin and other options that a neurologist can offer. And here's a sort of summary slide from that same publication, meta-analysis from 2021 earlier, that looks at the main types of neurosurgical interventions along the top and some of the possible outcomes, including pain freedom, which again, you may not be totally free of pain, but you may have less pain, as well as facial sensory changes, including numbness or decreased sensation of the face. There are other treatments also being looked at that we may have at our disposal in the future, including a medication that we call by the name of CGRP, which is actually a currently FDA-approved medication class to treat migraine. Again, migraine is a distinctly different disorder than trigeminal neuralgia. However, migraine is a headache disorder that does have a lot of relays and control and activation of the trigeminal nerve. CGRP is the name of a molecule or a protein in the body called calcitonin gene receptor peptide. And that little protein is released from a lot of the trigeminal nerve endings and does seem to have a pretty active role in pain syndromes. Obviously, migraine, where it has its FDA approval for, as well as cluster headache, which it has approval and data for. And that's a related condition to migraine and somewhat related to trigeminal neuralgia as well. And studies have shown increased levels of CGRP in people with trigeminal neuralgia, including in the spinal fluid, which again is that fluid that's a little bit more specific to the brain and spinal cord, suggesting that it could be relevant in other pain disorders like trigeminal neuralgia. So I've listed here some sources of different publications and research summaries that we have gone through and mentioned in the slides, some data points, and these are all actually freely available through PubMed, which is our free government-wide research-based database of studies in the medical world. And now in our last couple minutes, if there's any questions, I'm happy to take those.